Hi, everybody. This is Avash Kalra. I'm the course director for our hepatology and transplant webinar series. So thanks to everybody for being here today and listening in. Just want to also introduce and thank Dr. Cassie Zhu. She's an assistant professor in the Division of Pathology here at the University of Colorado and specializing in GI and liver pathology. And looking forward to today's talk. We'll give information in the chat about receiving CME and other useful details. I do want to just highlight that this is the first of 5 webinars that we have this year, and we do have a website that you can. I think you probably already have the link, but if not, you can look up UC Health Liver Transplant Webinar Series and find the schedule for the year. So with that, thanks again to everybody for joining and listening today. And Cassie, the floor is yours. Thanks again.
All right, thank you. Okay, I think some of these first slides are just, let's see, for CME accreditation. So disclosure of relevant financial relationships. All of us, the planners, faculty, and me, or I don't have any financial disclosures to disclose. This is the link for the evaluation. There's a QR code. I think they should be linking that into the chat somewhere. If not, at the end, I can put up the screen again. So today we'll be talking about liver pathology pearls to use in clinical practice. So our learning objectives for today are to, 1, start by reviewing normal histology, discuss the routine special stains that we do on our medical liver biopsies, what we're looking for on each stain and what the abnormal findings mean, and the differentials that that we have for these findings. We'll also review fibrosis staging and common patterns of liver injury, and then finally discuss common patterns of liver injury that we see in practice, and then talk about some differentials that we should consider when we see these patterns. Okay, so to begin, this is just an overview of normal liver histology. So when I'm looking at a liver biopsy, I think of the liver divided into 2 main sections. So I think about the portal tracts, and I think about the hepatic lobules. So the portal tracts are composed of 3 main structures. So we have a bile duct, which is this circular structure or ductal structure lined by these uniform cuboidal or square-shaped cells that are all lined up really nicely along the basement membrane. When we see damage to the bile ducts, we lose this uniformity. The cells start to look different from one another. We start to lose a polarity, so that some of the cells look like they're higher up and then some of the nuclei look lower down. And then sometimes we can see cytoplasmic vacuolization or white spaces within the cytoplasm. So when we see bile duct damage, we think of chronic biliary diseases. In the setting of transplant, we think of could be like lymphocytic cholangitis with bile duct injury and acute T-cell mediated rejection, etc. The other structures that we have are the portal vein. Seen here, it's a relatively thin-walled vessel, and the hepatic artery, which is a thicker-walled vessel. You can see the smooth muscle lining this hepatic artery. In terms of the hepatic lobule, it's divided into 3 zones. Zone 1 is periportal. Zone 3 is centrolobular around the central vein. And the hepatic lobule is composed of these hepatic plates that are trabeculating from the portal tracts to the central vein. And they're composed of up to 2 cells, so usually 1 to 2 cells in thickness, and you have intervening sinusoids in between. In terms of circulation, when we think about circulation, the blood typically flows from the portal tract to the central vein and drains into the hepatic veins into the anterior vena cava. Conversely, when we're thinking about bile flow, the bile flows from the from the lobules into the into the bile duct in the portal tract. So the first special stain we're going to discuss is the trichrome stain. So this is used to evaluate for fibrosis. So it highlights this collagen deposition. This is just an example of normal liver. So we expect to see some collagen deposition within portal tracts, and the degree of collagen deposition that you see in each portal tract should correlate with the size of the portal tract. So sometimes it's hard to evaluate stage 1 fibrosis in chronic hepatitis when we're looking for fibrous expansion, because you have to take into account the size of the portal tract that we see. In terms of the other, usually in the central veins, you get a little bit of collagen deposition, but it's pretty minimal. So in terms of staging, so I'm going to go over staging for steatohepatitis and staging for chronic hepatitis patterns of injury. So for steatohepatitis, many of us use the Brunt staging system. So the fibrosis starts in the central lobular zones, so zone 3. It's characterized by perisinusoidal, so the fibrils run along the sinusoids, or pericellular, so the fibrils here would wrap around the cells. And so this is stage 1. We call this chicken wire fibrosis. So this is what chicken wire looks like. And if you can like correlate this picture with that one, it looks pretty similar. So this is our stage 1 fibrosis in steatohepatitis. Stage 2 is where we have fibrous expansions of the portal tract, and then we have collagen deposition that's extending out of the portal tract. So like these thin fibrils are extending out. It kind of has like a spidery appearance to me. So this is stage 2 periportal fibrosis. And then stage 3 is bridging fibrosis, where you have a bridge of fibrosis extending either from the portal tract to the central lobular areas or between portal tracts. And then finally, stage 4 is cirrhosis. So we have bridging fibrosis that's all around these developed nodules. In steatohepatitis, the nodules in the cirrhosis tend to be pretty regular, small nodules. And then for chronic hepatitis pattern of injury, the difference here is really in stage 1 stage 1 fibrosis. So here, instead of the fibrosis starting in the central lobular areas and causing a perisinusoidal pericellular fibrosis or a chicken wire appearance, we have fibrous expansions of the portal tract. So these are relatively small portal tracts, and you can see there's a little more blue than you would expect in these areas. This can be kind of challenging. There can be like variation between pathologists. For me, I tend to show my other colleagues to make sure I'm not overcalling fibrosis here. And then like in steatohepatitis, stage 2 would be periportal fibrosis. So you have fibrous expansion of the portal tracts with extension of the fibrils into the lobular parenchyma. Bridging fibrosis, so you have a bridge of collagen deposition between portal tracts. And then cirrhosis, where you have bridging fibrosis with well-developed nodules. The next stain that we often perform is reticulin stain. So this highlights the reticulin framework. We use it to evaluate liver architecture, and it also can help us identify areas of fibrosis. So sometimes our trichrome stain can be a little understained or overstained, and we have a little trouble deciding if the fibrosis is real or not. So we can default to our reticulin stain to help us confirm or deny whether or not we have fibrosis here. And so typically, the reticulin highlights these hepatic or surrounds these hepatic plates. It's typically like this thin black line that's surrounding each of these plates. When we look for fibrosis, the color tends to be a little more brown and a little more smudgy in appearance. This is just normal liver. It's just showing you, the normal hepatic plates with 1 to 2 cells in thickness. When we abnormal findings of the reticulin stain, we're looking for things like nodular regenerative hyperplasia in HCC. So for nodular regenerative hyperplasia, this is a common cause of non-cirrhotic portal hypertension. It can look like cirrhosis on imaging. So we often get these on biopsies in patients with portal hypertension. So we're looking for alternating areas of thin hepatic plates. So the reticulin really highlights these plates here. You can see they're really thin in areas that look thicker in appearance or more hyperplastic looking, alternating with these thin areas. So on low power, you can kind of see it kind of looks like a lot nodular. You can kind of draw like a circle around this. These findings can be kind of subtle, but a pretty important finding to note on reticulin stain. So etiologic associations here would be collagen vascular diseases such as rheumatoid arthritis, lupus, systemic sclerosis, Felty syndrome, and polyarthritis nodosa. There's certain drugs that can cause this look. So oxaliplatin can cause this look. Androgens, corticosteroids, azathioprine, lymphoproliferative disorders, myeloproliferative diseases, prothrombic conditions, hepatic diseases. We can often see this in really old transplanted livers, and then CVID. And then the other disease that we consider when we have abnormal reticulin findings on the reticulin stain would be HCC. So in HCC, we're looking for thickened hepatic plates. So like I said, the hepatic plate should be composed of 1 to 2 hepatocytes in thickness. So here you can see an example of HCC where you have up to like 6 nuclei expanding the hepatic plate. You can also see areas of loss of reticulin framework. So we use this reticulin stain to help us make the diagnosis of HCC. The next stain is iron. So as the name suggests, we're looking for iron deposition here, really evaluating for hemochromatosis. So there's 2 main patterns of deposition. So primary pattern of deposition, which is iron deposition within the hepatocytes, and the secondary pattern of deposition where you have iron depositions within the sinusoidal Kupffer cells. So these are the sinusoidal areas, and you can see these blue granules within the cells that are in the sinusoids. So for primary pattern of deposition, typically the deposition starts within the periportal hepatocytes and extends onto the central lobular areas with usually the iron deposition is most in the periportal hepatocytes and less in the central lobular areas. When we think about primary pattern of deposition, we're thinking about like hemochromatosis. And then when we're thinking about secondary pattern of deposition, this is non-specific, but things like hemolysis, transfusion, hemodialysis, sickle cell disease. And then you can also get a combo of the primary pattern of deposition and secondary pattern of deposition. So you'll see some iron deposition within hepatocytes. You'll see some iron deposition within the sinusoidal Kupffer cells. So when you have a mixed pattern, it can either suggest like non-specific things like alcohol, liver disease, viral hepatitis, or it could suggest like long-standing other disease entities such as hemochromatosis. So eventually in hemochromatosis, you can get both mixed patterns of deposition. The next stain is periodic acid shift stain or PAS stain. This highlights glycogen. So not every lab will do it, but we do it at our institution. So for us, it's a good architectural stain. It highlights areas of hepatic plate atrophy, which we use for evaluating chronic venous outflow obstruction. We also can use it to highlight areas of necrosis. Sometimes it's hard for us to see it on our routine H&E stain. So this stain, which is like very magenta in color, can really highlight those areas. I have some examples that we'll look at next to really showcase that. So this is an example of geographic necrosis. So you can see the normal hepatocytes or the normal lobule has this really nice magenta color, and then you can see the areas where the hepatocytes have died. And so this really highlights the amount of necrosis here. This is an example of HSV-associated hepatitis, which has this geographic necrosis appearance. So it's like a cluster of necrotic hepatocytes. It's non-zonal, so it doesn't really have a specific pattern. So could be either periportal, it can be central lobular, kind of scattered throughout. This is an example of atrophy of the hepatic plates. So you can really see areas where you have sinusoidal dilation, and then you can compare with the more normal looking hepatic plates and the hepatic plates in these areas of sinusoidal dilation, and they look thinned out. So this just kind of helps us make that diagnosis of chronic venous outflow obstruction. And the final stain that we have is our PSD, so periodic acid shift diastase. So this stain will digest out the glycogen, and what we're looking for here is mainly for alpha-1 antitrypsin globules, which is an acute phase reactant. which is also non-specific because it can be seen in underlying inflammatory conditions like acute and chronic hepatitis, inflammatory diseases. But we can also use this PASD to look for, also highlights like serine-laden macrophages, which are like the cleanup cells in the liver. It can also, you can also get like copper-associated binding protein deposited in the periportal hepatocytes, which might suggest like a chronic biliary disease, such as PBC or PSC. So if you see that, that's kind of what it might suggest. So for alpha-1 antitrypsin globules, so typically in alpha-1 antitrypsin deficiency, the globular deposition is within periseptal or periportal hepatocytes, and they tend to be relatively large, round globules. In some phenotypes, the globules might be more granular in appearance, but this is a classic example of alpha-1 antitrypsin disease. You can see the globules are deposited in the periseptal areas. Occasionally, we can see lobular alpha-1 antitrypsin globules. A lot of times we see these in our post-reperfusion biopsies, but you can see these are small globules that are kind of scattered throughout the lobular parenchyma. We think this is more like non-specific. If we see like periportal deposition of the globules, we might suggest alpha-1 antitrypsin deficiency more so than here. But we always at least I always put on the differential to do some additional testing to rule that out. So alpha-1 antitrypsin globules are intracytoplasmic accumulation of abnormal proteins with endoplasmic reticulin. The presence is really dependent on the phenotype of the patient age, the severity of the inflammation, and degree of fibrosis. So for patients with PIZZ phenotype, those tend to have the most abundant globules, and they tend to be the classic like periportal globules. And then PIMZ, so they have one's normal, one's the abnormal Z. They can have a deposition that ranges from granular material to large globular deposits. And then for patients with PIS S phenotype or PIMS phenotype, typically this protein doesn't polymerize easily, so globules, to my knowledge, have not been described in the literature. If we see globules on alpha-1 or on the PASD stain, we also have like a confirmatory immunohistochemical stain that will highlight these globules to further confirm their presence. And then in terms of background findings for alpha-1 antitrypsin deficiency, there's really not a specific look. So you might see like neonatal hepatitis in the background, a biliary pattern of injury, chronic hepatitis. You might just see cirrhosis. You might just see mild steatosis. These are just more examples of biopsies of alpha-1 antitrypsin deficiency. So here, this is a routine H&E stain. This is a portal tract, at the edge of a portal tract. You can see these periportal hepatocytes with these pink cytoplasmic inclusions. This is a PASD stain that highlights these globular inclusions more readily around these portal tracts. Okay, so when we get our H&E stains slides, we look at the biopsy. We have this pattern-based approach to evaluating the liver. So we go from low power, see what the big picture is, and go at higher power to look for additional findings that might sort the findings of the biopsy into a specific category. So the main categories that I think of, this is a relatively simplified way of looking at it, but I think of, does the liver look bubbly? Is there a lot of steatosis? Does the liver look inflamed? Does it look blue? Where is this inflammation? Is it in the portal tracts? Is it in the in the lobules? Does this look more like a biliary injury? So is there cholestasis, or do the bile ducts look really damaged? Is this more of like a vascular flow abnormality? So is there like either a vaguely nodular appearance on the reticulin stain, or is there clear sinusoidal dilation in the central lobular areas with associated hepatic plate thinning? Or are there inclusions or miscellaneous deposits that might suggest a specific disease entity? So when I sort it into like these 5 wastebasket categories, or 5 categories, I start to look on higher power and try to make give a more specific pattern. So for example, for steatosis, I'm evaluating if it's microvesicular steatosis predominant or macrovesicular steatosis. And if it's macrovesicular steatosis, I'm looking for additional findings to maybe suggest steatohepatitis. So for biliary injury, obviously the lab abnormalities have more of a cholestatic pattern, and for these steatosis and inflammation hepatitis, it's more of a hepatitic pattern of injury. So next, we're going to kind of discuss these three main categories and differentials to consider and common diagnoses that we see in each of them. So the first one is steatosis, or the bubbly liver. So this is either macrovesicular steatosis or microvesicular steatosis. In some cases, you can get a combo of either. So macrovesicular steatosis, we define that as small to large fat droplets that you can count that may or may not push the nucleus to the side. So this is an example of macrovesicular steatosis here. You can see these circular white spaces within the hepatocytes. So the large droplet ones are the ones that are bigger than a nucleus in size and push the nucleus to the side. The small droplet ones are the ones that are about the size of the nucleus or smaller and not pushing the nucleus to the side. Conversely, microvesicular steatosis is where you have innumerable fat droplets. So these droplets are very, very tiny, but you really can't count them. And they give kind of like a foamy appearance to the liver parenchyma instead. And it's important to make the distinction. So if you only have microvesicular steatosis, the differential is different. So this finding is thought to be secondary to impairment of beta oxidation. So the differential here would be like acute fatty liver pregnancy, drug reactions specifically to valproic acid, amiodarone, or nucleoside analog toxicity, fatty acid beta oxidation defects, Rye syndrome, mitochondrial DNA depletion and deletion syndromes, TPN, alcoholic foamy degeneration, and inborn errors of metabolism. And so the differential is different. Granted, in MASH and alcoholic steatohepatitis, you can get a combination of macrovesicular and microvesicular steatosis. So this is just another example of microvesicular steatosis. So you can see there's all these tiny, tiny fat droplets within the hepatocytes, and really can't count the number of fat droplets in there. So this is how we make that diagnosis of microvesicular steatosis. So for the steatosis pattern of injury, alcohol liver disease is a very common diagnosis to consider. So alcoholic liver disease is an overlapping morphologic spectrum. So typically we start with simple steatosis, which tends to start in the central lobular areas. And then it can progress to alcoholic steatohepatitis, where we have inflammation, we have ballooning degeneration of hepatocytes, and then fibrosis, and then eventually end stage alcohol liver disease, where we have cirrhosis. And again, the cirrhosis is typically characterized by small round nodules. So for alcohol fatty liver disease, typically we see steatosis. Like I said, it's typically starts in zone 3. We can sometimes see lipogranuloma. So this is characterized by collections of inflammatory cells around the fat droplets. And then sometimes we can see mega mitochondria. So these are pink inclusions, kind of like our alpha-1 antitrypsin globules, but they're typically not typically in the areas of fat, so typically zone 3 to begin with, and then you won't see them on PESD stain. And so this is usually this is more common in steatohepatitis or people who have heavy history of heavy drinking, and this is just a marker of oxidative stress. I know that not all pathologists will note this in their microscopic description, but it's something that they might see in alcohol fatty liver disease. And for alcoholic steatohepatitis, there's 4 main features that we look for. So steatosis, hepatocyte ballooning, lobular inflammation, and fibrosis. And so different pathologists have different criteria of what they need to definitively call alcoholic steatohepatitis. I'm aware of some pathologists requiring fibrosis, some pathologists requiring balloon hepatocytes to call steatohepatitis. At our institution, we're a little more flexible. So usually it's a combination of the factors, these 4 factors. So definitely I want to see steatosis. If I see hepatocyte ballooning, but I don't see fibrosis, I'll still call it steatohepatitis. Or if I see steatosis, lobular inflammation, and fibrosis, especially like this chicken wire fibrosis that I was discussing, then I'll call it steatohepatitis. So there is some kind of variation within pathologists of what they'll definitively call steatohepatitis. So we talked about steatosis, so hepatocyte ballooning. So this is these are like hepatocytes that look like way larger than normal. They have the cytoplasm looks more cleared out or more white, and then you have these thin fibrils, or in some areas thick fibrils, called Mallory Dank bodies. These are just aggregates of cytoplasmic material. Um, these are, typically larger than your normal hepatocytes. These are all in zone 3, or the central lobular areas. And then lobular inflammation, that's self-explanatory. So you'll have inflammation within the hepatic lobules, and then fibrosis, which we discussed previously. So this is just more examples of lobular inflammation. So you can see this is a central lobular area. You have steatosis, macrovesicular steatosis here. You have areas of balloon hepatocyte. So this larger hepatocyte that has a cleared out cytoplasm, and then this ropey-like material within the cytoplasm. So Mallory Dank body, so consistent with a balloon hepatocyte. In association, you see these foci of lobular inflammation. You can also, this inflammation tends to be mixed. You can also have neutrophils within this inflammatory infiltrate. And again, so this is a staging that we do for steatohepatitis. So this chicken wire fibrosis is very characteristic for steatohepatitis. Sometimes we'll get end stage, like end stage cirrhosis biopsy, and the challenge there is to decide if we can see a reason why the patient had cirrhosis. So sometimes we'll see this chicken wire fibrosis and maybe a little bit of fat in the background. And when we see this chicken wire type fibrosis, we might suggest the possibility that that patient might have a burnt out steatohepatitis. And again, this is the grading and staging that we do. This is a Brent scoring system. So the grade is based off the amount of steatosis, the ballooning, and the degree of inflammation in the portal and lobular portal tracts and lobular parenchyma, and the fibrosis is used for staging here. The next pattern of injury is chronic hepatitis pattern of injury. So this is typically, we're looking for inflammation, so portal or periportal inflammation, and lobular inflammation with or without necrosis or hepatocyte damage, and then commonly fibrosis. So the differential here would be drug-induced liver injury, viral hepatitis such as Hep B and Hep C, and autoimmune hepatitis. So this is an example of just portal inflammation. You can see the portal tract is expanded by this inflammatory infiltrate. There is a little bit of interface activity where the inflammation spills over into the lobular parenchyma. This here is just showing you some lobular inflammation. It's pretty minimal, but there's some acidophil bodies, which shows that there's hepatocyte damage here. And then one of the common entities that we think about for this chronic hepatitis pattern of injury is autoimmune hepatitis. So again, this is a progressive immune-mediated inflammatory liver disease. Has a highly variable clinical presentation. I'm sure you're aware. Lab findings are elevated transaminases, increases serum IgG. They can have autoantibodies, so anti-smooth muscle antibodies, anti-nuclear antibodies. They may have an anti-liver kidney microsoma antibody. And then of note, Hep C antibodies can be falsely elevated in these patients. So this is an example of autoimmune hepatitis. So we have portal inflammation here. The inflammation looks like it's centered around the interface. So the interface, again, is where the portal tract meets the lobular parenchyma. And then the inflammation looks like it's spilling over. There's many plasma cells here, and many plasma cells participating in the interface. And then within the lobular parenchyma, you can see clusters of inflammation. It's plasma cell rich, and then associated hepatocyte damage. So technically, there's no pathognomonic histologic feature for autoimmune hepatitis, but when we look for autoimmune hepatitis, we're really looking for if there's a conspicuous plasma cell population, and if there's good interface activity, if there's fibrosis, and if there's necrosis. So typically, we see dense portal-based inflammation, tends to be mixed lymphocytes, histiocytes, and many plasma cells. It's can be striking, but it's not pathognomonic for it. Often you see interface activity where the inflammation spills into the lobular parenchyma, and then you start to see portal-based fibrosis, and then which extends to periportal fibrosis, bridging, and then cirrhosis. You also see lobular inflammation scattered throughout the lobular parenchyma with associated hepatocyte damage. Again, this inflammation can be mixed, but usually you see a lot of plasma cells. And then occasionally in the portal tracts, you can see some bile ducts that have lymphocytic inflammation that's invading into the bile duct or lymphocytic cholangitis. But typically this is pretty minimal or mild. So again, interface hepatitis, this is defined by, the interface is where the portal tract meets the hepatic lobule. And again, this is defined by the portal inflammation spilling over into the lobular parenchyma here. So this is just drawing the interface, and you can see there's a plasma cell-rich inflammatory infiltrate spilling over. So this is an example, another case of autoimmune hepatitis. You can see there's a lot of plasma cells. It's plasma cell-rich lobular inflammation that's scattered throughout the hepatic lobule. It's kind of hard to visualize the portal tract. I think this might be one here, but you can see there's necrosis of the hepatocytes here. Here in this area, you should see normal hepatocytes intervening, but they're all gone. You have this, it kind of has this pink appearance here, and then we can use our P as D stain to highlight this area. So this is consistent with bridging necrosis, which would be a grade 4 severely active autoimmune hepatitis. So for the grading and staging, the Ludwig system is the most commonly used. That's what we use at our institution. And this takes into account the degree of activity in the periportal/periportal areas and the lobular areas. So we use whatever is the highest degree, and that's how we grade it. And then fibrosis again is, or staging is again fibrosis, and then the fibrosis here starts in the portal tracts. This is just another example of bridging fibrosis where you have loss of the hepatocytes and you have inflammation here. And then this is actually a trichrome stain that highlights the areas where the hepatocytes are lost. One caveat to note is that when you have bridging necrosis like this, when we're trying to stage this patient, it can be challenging because of the degree of dropout and the degree of inflammation. So sometimes that can like alter the appearance of the trichrome stain, and it makes it hard to give an accurate assessment of fibrosis and staging. Okay, and the next pattern of injury is are like the biliary patterns of injury. So when we suspect a biliary pattern of injury, there's a few things that we consider. So we look at the bile ducts, we ask ourselves, is there a lot of inflammation in the portal tracts? Is there a lot of inflammation that is affecting the bile ducts? Or is it really posse immune? There's really not much inflammation, but the bile ducts look injured. Are the bile ducts still present? Are they lost? Does it look immune mediated? Is it alloimmune or in the setting of transplant? And then we also look to see if there's cholestasis here. So one of the common diagnostic considerations is primary biliary cholangitis. So this is a chronic cholestatic disease characterized by destruction of small and medium sized interlobular bile ducts with progressive fibrosis that eventually leads to cirrhosis. Typically, as you know, female predominant, peak in the 5th decade. Symptoms are fatigue, pruritus, hyperlipidemia, hepatomegaly. Some are asymptomatic. Lab findings, as you know, elevated AST, ALT, elevated alk phos, AST, ALT normal or mildly elevated, elevation of IgM, AMA, positive AMA. Some people have ANA, and then SMA in up to 2/3 of patients. So as you know, only two of these 3 diagnostic criteria are needed. So AMA, elevated alk phos for greater than 6 months, and having histologic findings on biopsies. One of the challenges on biopsy is that the findings for primary biliary cholangitis may be really patchy. So the patient may have PBC, but our biopsy might not show any features that may be suggestive of it. So it really is a patchy disease. So it kind of depends on sampling sometimes, whether or not we can see things in our biopsy. So these are the characteristic histologic features. So we're looking for portal tract inflammation. So like in autoimmune hepatitis, there's portal inflammation here. But when I see portal inflammation, I'm asking myself, is the portal inflammation more around the interface or on the edge of the portal tract where with the lobular parenchyma, or is it more bile duct centered? So if it's more bile duct centered, then I'm thinking maybe I should consider PBC. If it's more along the interface, then I'm thinking maybe this is more like an autoimmune hepatitis. The inflammation is mixed, but it could also be plasma cell rich. Um, and then you can often see lymphocytic cholangitis. So that's when you have a bile duct and you have lymphocytes involving the bile ducts and causing damage. The classic hallmark of PBC is non-suppurative cholangitis. Oftentimes we can see these floor duct lesions, which are pretty characteristic of PBC. So this is an example. So we have the portal inflammation centered around the bile duct. The bile duct looks damaged. Typically, it has more of like a vaguely granulomatous appearance. This is just another example of lymphocytic cholangitis. So this is a portal tract. We have a bile duct here. You can see some lymphocytic inflammation. In the bile duct here, you can see it doesn't have that nice cuboidal appearance. The nuclei are really different in size. You don't have polarity around the duct, around the basement membrane here. So this is good for bile duct damage. Okay, so there's some additional histologic features that you might see in PBC. These are some features that we might see when we don't have like the classic floor duct lesion, classic portal-based inflammatory infiltrate causing bile duct damage. So sometimes we can see colate stasis. So this it looks like balloon hepatocytes, but the location is in the periportal hepatocytes, so around the bile portal tracts. And this is secondary to bile acid damage. So it has this balloon appearance. So this might suggest a chronic biliary process. You can also see, we can sometimes do a copper stain, and then it'll highlight, there'll be like granules around the periportal hepatocytes, which might suggest a chronic biliary disease process as well. In PBC, you can sometimes see lobular inflammation, but this tends to be minimal to mild at most. If we see prominent lobular inflammation, we start thinking about some kind of overlap with the secondary disease process. And then finally, for end stage PBC or patients with PBC with cirrhosis. The cirrhosis is different from what we would see in chronic hepatitis and in steatohepatitis. So instead of the nice round regular nodules, they have irregular jigsaw puzzle shaped nodules. So it's not really nicely round and regular. So you can see this is kind of like an irregular shape. And then sometimes you'll see colate stasis around these periseptal hepatocytes, giving like a halo appearance. So again, if we have like a biopsy for end stage cirrhosis, or if we have like an explant where they don't know the primary etiology, if we see this pattern of cirrhosis, we could suggest the possibility of a chronic biliary disease such as PBC. And then finally, like I said, there's portal inflammation. Sometimes you can see spillover or interface activity here. Typically, this is typically minimal. If it's more than minimal, if it's like pretty moderate and then or severe, then we might start thinking about a secondary disease process such as like an overlap syndrome with autoimmune hepatitis. You can also see ductopenia. So if you imagine you have all this inflammation centered around the bile duct, it's causing bile duct damage. Eventually you'll get bile duct loss. So this is just showing you a portal tract where we have the portal vein and hepatic artery, and then we don't have a corresponding native bile duct. So this is bile duct loss. Sometimes you'll see ductopenia in the reports. And for us to classify something as ductopenia, we need to see greater than 50% of the portal tracts without native bile ducts. For staging for PBC, so there's two different staging systems that are described. So there's the Schroyer system and the Ludwig system. For both systems, stage 1, 3, and 4 are similar. So stage 1 would be portal inflammation with bile duct damage with or without floor duct lesions. 3 would be bridging, 4 would be cirrhosis. And then the difference between these two is for stage 2. So Schroyer says ductular reaction, Ludwig says periportal inflammation. I think we use a Schroyer system at our institution. So I just want to show you an example of overlap syndrome with autoimmune hepatitis and PBC. So for these biopsies, I see portal inflammation, and some of the portal tracts tend to have interface inflammation centered around the interface and interface activity. So here, this is the portal tract here. A lot of the inflammation is around the interface and there's good spillover. So it's probably mild to moderate in degree. It's plasma cell rich, but again, you can get plasma cell rich inflammation in both autoimmune hepatitis and PBC. And then I look for areas where the portal tracts have more inflammation that's centered around the bile ducts. So this is just, so for this, the inflammation is more centered around the bile ducts. And then I look for a bile duct injury. So this is a high power view of that. So you can see the native bile duct is here, and then you have all this lymphocytic cholangitis here, and it vaguely looks like a forward duct lesion where it almost looks granulomatous in appearance. So this is a good example of autoimmune hepatitis where you have a good degree of interface activity overlapped with PBC, where you have nice portal-based inflammation with associated bile duct damage. And then the other thing that we consider for a cholestatic or biliary type liver injury, we can often see large bile duct obstruction. So this is caused by stricture, surgical ligation, gallstone, or malignancy. We see this a lot with our transplant, post-transplant patients. So the labs here are elevated alk phos or conjugated bilirubin. And conjugated bilirubin. So histologic features that we look for are portal edema. So the portal tracts, instead of being nice and compact, they look expanded, but it's not expanded by inflammation. Instead, there's it looks more like fluid or edematous in appearance, bile ductular reaction, and cholestasis. And this tends to start in the central lobular regions. So differentials that we include when we see this kind of injury include drug-induced liver injury, ischemic cholangiopathy, and other chronic biliary diseases. So this is an example of cholestasis in the central lobular area. So this is a central vein here. And then you can see there's bile deposited within the canaliculi and within the hepatocytes. And then you could see this feathery degeneration associated with this cholestasis in this area. So they kind of look ballooned in appearance. This is what I mean by bile ductular reaction. So you have these small duct profiles, usually on the edges of the portal tracts. Typically, you'll have like a normal native bile duct in the middle that tends to be a little larger. With this bile ductular reaction, we often see periductal neutrophils. So we see a lot of neutrophilic inflammation around these small bile duct profiles. Again, this finding is not entirely specific either. And then the other finding is portal edema. You can see that instead of the portal tract being nice and condensed, you can see there's like kind of whitish spaces expanding the collagen within the portal tract. Okay, and so the final thing we're going to discuss today is drug or herbal-induced liver injury. And so there's not a specific pattern of injury for DILI. DILI can present as necroinflammatory acute hepatitis, cholestatic pattern of injury, steatosis, vascular outflow, chronic hepatitis-like. So it has, depending on the drug, it can cause different types of patterns. So I feel like it's always on our differential. And then there are various charts that you can find for different drug types with different specific patterns that you might see. And then the classic one that we learned in med school at least is acetaminophen toxicity. And so this is characterized by central lobular geographic hepatocyte necrosis. So these are central veins. And then you have necrosis of the hepatocytes in zone 3 around these veins. This is just a higher up picture of the necrosis that you see in acetaminophen toxicity. So you don't have it's pink and fluffy, and there's no nucleus seen in the necrotic hepatocytes. Okay, and then this is the end of my talk. Let me know if you have any questions. Thank you for your attention and for your attendance. Okay, let's see. I see a few questions in the chat. So The first one is I hear from many GI providers, especially in the community, that there's sometimes confusion in clinical practice when evaluating for autoimmune disease. I personally think that many patients get labeled as AIH PBC overlap as opposed to just PBC because there is some inflammation that extends beyond the beyond the bile ducts. And maybe there are a few plasma cells. You mentioned looking for conspicuous. Do plasma cells equal autoimmune hepatitis? No, plasma cells do not necessarily mean autoimmune hepatitis. But when we see a plasma cell rich interface hepatitis with lobular inflammation, we feel that feels more like an autoimmune hepatitis, but drugs can cause that pattern. PBC, like I was saying, can also have plasma cells in the inflammatory infiltrate, but typically the inflammation is centered around the bile duct and there's bile duct damage. There can be some interface activity, but usually it should be pretty prominent, and there can be some lobular inflammation, but again, that should be more than just like minimal or mild. And then let's see, some inflammation. And then to call if you have someone that has for sure autoimmune hepatitis, the question is like, at what point would I suggest overlap with PBC? So when I see good bile duct damage, if I see 4 duct lesions, then I'll suggest the possibility of an overlapping PBC. And then, are there any other pitfalls or common misconceptions related to liver pathologies reports that you tend to see? Um, I think a lot of people label things. I think a lot of people, I noticed that like for us, we tend to downgrade the staging. So a lot of people will call like bridging fibrosis, but a lot of times it really isn't. It's more periportal or there's no significant fibrosis. And that kind of depends on like, sometimes their trichrome stains a little more strong or is a little more weak. And again, I was talking about like the portal fibrosis stage 1 for the chronic hepatitis. I think that can be kind of challenging because it's kind of like a gestalt of, you've seen so many normal livers, kind of have an idea of how much collagen deposition you should have in each portal tract. So you have to extrapolate that information and see if there's actual like expansion of the portal tract. So I think that can be kind of challenging sometimes. And sometimes our threshold for calling things steatohepatitis is different from other people's. So sometimes for cases, they might see some steatosis, they might see some lobular inflammation, but sometimes we feel like it's enough to call steatohepatitis. We might find one rare balloon hepatocyte. So sometimes we change our diagnosis based off of that. And then one other thing to know about autoimmune hepatitis. So sometimes for me at least, I'll give the pattern of injury. So the pattern of injury might be like interface and lobular hepatitis, and then I'll say see comment. And then I'll usually include like a differential. So it's usually drug-induced liver injury, viral hepatitis, and autoimmune hepatitis. If it doesn't look plasma cell rich, then I still keep it on the differential. I'll just say the histologic score would be a 1. So 1 is like it could be autoimmune hepatitis. 2 would be it's definitely, I think it like really looks like autoimmune hepatitis, and 0 is it's not autoimmune hepatitis. So sometimes autoimmune hepatitis can present in like a non-specific pattern. Okay, let's see what else. Okay. I think that's all the questions that I see. Okay. All right. And the last thing is that there's a Rocky Mountain highlights in gastroenterology and hepatology conference on August 9th at the Anschutz Health Science Building. All right. Thank you so much.